So Lucy asked me to talk a little bit about overcoming barriers in a conversation, and at first I thought, what can one say about it? And then my first set of slides was 50. So there's a lot that one can say about it. I did cut it down, and I'm going to race through it. So these are just some of the opportunities. And let me just frame a little bit that I am primarily a clinician. I identify myself that way. I did do research, but it was in biochemistry, which is very reductionistic. And I do some research here, but a lot of this comes from just my experience as a clinician and working with other people in the clinical practice, as I'm sure it is for many of you. So some of the barriers are included here. Definitions, lack of training and competence is a huge one. Organizational support, relevance, there's more important things to do than this. Disease-oriented focus, we already talked about that a little bit. I think Wilt, you talked about the cure orientation. That's a barrier. And the list goes on. So I'm just highlighting some of these, and I'm going to talk a little bit, very briefly, about some of the research. But I have some challenges in there for us to think about. Now, I think we've already encountered this already here. We're talking a lot about the definitions, what our personal definitions are, what the definitions were that were developed. I love some of the modifications actually in the 𝐒𝐓𝐔𝐃 definition and thinking of how we can sneak those back into ours. But I remember I'm from the United States, so I'm going to talk a little bit from that perspective. But there is a huge conflict between religion versus spirituality and its appropriateness in care. And what I put there as one of the issues with the methodologies is, again, a lot of our research initially was around religion, which makes sense because it's easier to measure. You can ask affiliation, you can ask, I'm surprised you didn't find any in your systematic review, you can ask demographics. It's a little bit easier to do. Harold Koenig's excellent work, Duke Religious Inventory, there's things that you can actually concretely measure. Spirituality is a little harder to define, so then how do we measure it? And I think that's also a negativity. And in our country, people will, the skeptics will say, but look, all the research is about religion, and there's no room for religion in clinical care. That's a bias in our country, in large part because there's certain religious groups that have a lot of political how shall I say, influence. And people are nervous. They're nervous about proselytizing. So that's a huge factor, at least. But this was already mentioned, that we do need some uniform definition of spirituality, and those are the attempts behind these definitions. And then there's turf issues. We have a lot, for example, in medical education, a lot of my work has been in education. There's turf between humanities. This really belongs under humanities. Now, religion is under culture. Religion versus spirituality. So there's a lot of turf issues in terms of looking at this work and saying, this really what you're talking about is humanities. This belongs in my category. And Sloan, by the way, if you want to hear a lot of criticism, Sloan, who is a psychologist but is actually not a clinical psychologist, he's a research psychologist, but he speaks out very clearly that there is no room for religion unless it comes from the clergy in clinical care, and the rest of us should not be involved in that. Then, physician believes that it's really not our responsibility, and Sloan, again, is the one that has done this. This is an article by Chibnall, no relation to health, no time to address religion, and again, that's another limitation that religion was looked at. So in our country, for example, recently, I've developed courses on spirituality and health. Over 75% of the medical schools have courses, but there was a survey that went out that asked, do you teach religion and health? And actually, I'm surprised that they got 50%, but they have fewer numbers because our courses don't explicitly necessarily include religion. So even in that kind of a survey, if your first question is, we just did another study where we found our first question is, are you religious? That immediately set off the tone with people. They didn't want to complete the other survey, or any time we brought up spirituality, they thought it was religion. So now we're going to redo this. This is some work with medical students. We're going to ask the demographics at the end, because we don't want to bias the respondents. That's how touchy the situation is. Now, in terms of comfort level, there have been a number of studies that have said, well, docs really aren't that comfortable. But some more recent studies, this was out of 2006, some colleagues of mine in Texas, in Galveston, there was a unanimous conviction that addressing patient spirituality leads to better healthcare outcomes and doctor-patient relationships, and that addressing spirituality requires sensitivity, patience, tolerance for ambiguity, dealing with time constraints, etc., being sensitive to one's own spiritual place. So people say, sure, I'm comfortable doing it, but as I'll talk about more this afternoon, doesn't necessarily mean they're doing it. But 4 main themes emerge, and I think I read that from Will's talk as well. Out of that study, the nature of spiritual assessment and practice. What is that? We've already heard that just now, so I'm not going to go into that. Experience of connecting spirituality with medicine. One of my Hindu residents saying, I'm very spiritual, but that's from 6 p.m. to 6 a.m., not during the day. How do I connect that to my practice? Personal barriers to clinical practices, and then strengths of a more integrated approach where chaplains and others are included. This was a study, a couple of studies, this people now looking at different specialties. So psychiatrists have a greater comfort level than other specialties of physician. Barr Perlin, who's an excellent researcher and does a lot. He's with Dan Macy now at University of Chicago. They have a very huge effort there in research, at least at some functional level. Maybe not very deep, but at least at some functional level. And I think it's because they're trained more in counseling and they see that more as part of their role. Primary care physician survey would not initiate any involvement with patient spirituality unless they were dying. And that gets again into definitions. We do define palliative care very early on. And if a patient requests some involvement from in spirituality, most physicians are willing to comply if it's patient-led, but they won't take the initiative. In that study, about approximately half of the primary care residents, no, this was another story, sorry, that I was involved in. Approximately half of the primary care residents felt that they should play a role in their patients' spiritual or religious lives. And they felt that these activities were important and that they depended on the patient's condition. So this was a study in looking at primary care residents, which included internal medicine, pediatrics, and other, let's say, also family practice as well. And all of those residents said, yes, I think I'd like to be involved, but it depends on the patient's condition and also on my personal characteristics. So residents that weren't very spiritual and or religious were not as inclined to do this. Another study, again in family practice, saying that some of the greatest level of discomfort had to do again with training. If we were trained, we would do this. Uncertainty about identifying those patients that might be interested in having a conversation. I take a very different approach. I mean, how many patients would be interested in discussing their sexuality? Not really many. But so that's the question, and then they have an opening, and so they discuss it. So I come at it from a little bit different perspective, but that's what this study was, that we have to identify those that are interested, and then we'll talk to them. Concerns about proselytizing, and then management. So we raise it, but what do we do about it? There's no chaplains yet in outpatient settings. Another study, physicians differ in their comfort level. So there's many studies like this, looking primarily at comfort, at their role, at familiarizing factors, etc. Training, we have done a lot of training. We've developed a competency-based training. Nurses have as well, but there's still questions about role. And what one of my friends, George Hanso and George Frischette, talk about is chaplain dumping. If there's a chaplain around, they can do it, we don't need to do it. So we can talk about that as well, because that's, I think, the key factor. People wanting we need greater details on assessment and treatment, and I've heard that from previous talks. But what I haven't heard yet is, I may have heard it in some of the questions, is that the strongest support, actually, from all of this great stuff that my colleagues and other people have done on competencies, the greatest support now comes from professional development. So we're doing reflection rounds, but that's accepted because people recognize that it's part of professionalism. So that's an opportunity, actually. And then organizational support, a lot of surveys that show, well, this came from McSherry's work, but that we're not really supported by organizations. So we may want to do it, but there's not much support. And yet if you look there, and we've heard this already, there are many guidelines. And so what's the opportunity really here? Well, CEOs of hospitals in the United States, this is what they want. This is the kind of research they want. Show me it's clinically relevant, give me some standards, give me some tested interventions, and we'll do it. So that's an opportunity. Ethical concerns, I think I've mentioned this already, boundaries, proselytizing, time. If I only have, I have 20 minutes, I know doctors here have 8, and I'm fearing we're going to get there. but if I only have 28 minutes, what do I do in that precious time as a doctor? I shouldn't really be addressing spirituality. Let me just get to the chest pain, the heart disease, the diabetes, and someone else will deal with spirituality. I think that's a big mistake, but who on the team should address it? So again, that's a big question as to who's trained and who's better to address it. This was just, again, about the recommendations of our consensus conference that we be aware of ethical issues. And this was a huge, huge piece of the discussion that we really need very strict guidelines on what's appropriate, what isn't, and who does what. And a recommendation that we all have a spiritual practice. So that's, so opportunities in this area. I think we need more updated studies on clinician preferences, and we need to use the broader definitions. As I said, many of these things have started with religion studies. We need clear ethical guidelines. We need some standardization of training for chaplains and certification, and this comes from my chaplain colleagues. We need training ourselves, the clinicians, better dissemination of guidelines, things that and whatever we've already heard. Now, clinical relevance. There's a lot of work, mostly from surveys, that show that spiritual beliefs impact all of this. And this, by the way, is an avenue of getting doctors to listen to this, by the way, because everybody has trouble with advanced directives. And this is across care in general, it's not just palliative care. People understand this notion of patient understanding of illness, so if religion, spirituality, culture, those kinds of things affect it, then it's okay. This notion of healing is not quite so well understood, but it is different from cure, and people welcome that definition. Medication compliance, of course, everybody wants to know if something impacts that, they'll do it. And then Balboni's study. Tracy Balboni has a lot of work now on spiritual care, defined not pastoral care, but chaplaincy care. And people who received chaplaincy care chose hospice more, had a better quality of life at the end of life. I would really recommend her studies. And then this whole notion of miracles that people are very uncomfortable about, but if you give them tools, they'll welcome that. There's also these kinds of things, and again, I think you all know this, but there are other studies that actually people do listen to. And then stress management is, and I've mentioned this study already. People are very interested in stress management. Let me just talk about this slide for 1 minute, because I think it's important. I've heard themes of this. There is psychoneuroimmunology that supports some of this work, and people are really hanging their hats on that, meditation studies, etc. But then if you look at the experience, traditional cultures have always believed in these healing experiences. They didn't need research, they believed it. So I just want to raise this as something for us to think about, the notion of mystery. Are there some things that simply cannot be reduced and cannot be measured and should not be measured? I'll just put it out there. So what is, some of the limitations in some of these studies that I just mentioned is it's fine, but what does it mean in terms of practical implications? So there was a study out of the Healthcare Chaplaincy Organization that says the #1 need of patients in a hospital are to be loved and feel a sense of belonging. Well, how does that then translate into spiritual care or into any kind of care? They encourage doctors to be compassionate. Everyone has that. All hospitals say we're compassionate. But then that implies training, which implies time, and if it doesn't really impact care enough, why are we going to put resources, workforce, and others into it? Another reason for that area of research. So these are just some of the ideas that are missing, and I think, when we look at stuff in the groups, I think we can look at a lot of this. I just want to highlight, I've heard it already, we really need creative research. Clinically controlled trials may not be the way to go. So we really need to think about very creative research studies, and I would love to see physicists and others involved in this dialogue. Now, clinical models, I've mentioned already we did that. There are those kinds of models. There are assessment tools, that's already been brought up. So opportunities really in using this model is to build on the existing curricula and models, pay attention to them, build on them. What other related fields can we fit into? So in my university, wellness is okay, a topic to use. I don't think this is entirely just wellness, but if they're going to listen, we can sort of work with them. Stress management is another. Whole patient care is huge. Whole patient care is huge. And if you can talk about whole patient care as biopsychosocial spiritual, which is of course the foundation of palliative care, people tend to listen to that. Humanities. I think when there are QI, quality improvement initiatives going on, just put in a question or two around spirituality. It's not ideal, but it gets the word out there. And George Fischette and George Hanzo, who lead a training chaplains to do research project in the United States, are recommending things like this as well. And then we've heard about patient advocacy and involving patients in policy debate. I've talked a lot about this. For clinicians, we are all stressed out. I would love to have that beginning meditation for all medical school classes. We are all stressed out. Providers are stressed out. Chaplains meet that need now. So find places where we can work with things that provides a way to address suffering. People want to know how to deal with suffering. They actually want to know how to deal with total pain. If we can say this gives you the tools to do that, it really helps people. And I think all of us should be writing books, presentations, that gets the word out there as well. So I think that's it. Thank you very much for your attention.